Leadership Academy Foundations of Medical Education video series. Watch to learn what advice Dr. Brittany Goodrich-Braun would give someone considering becoming GME faculty.
So my name is Brittany Goodrich-Braun. I am a current faculty at the Fox Valley Family Medicine Residency here in Appleton, Wisconsin. I started working in GME about 3 years ago, where I worked as a community preceptor with family medicine residents from this program. And they came to my, at that time, my clinic site and did part of their continuity clinic there. And through working with them, I learned that I really missed teaching and really loved GME. And that kind of brought me to be a full-time faculty here at our program.
What motivated you to consider becoming faculty?
At my previous clinic, I was outpatient only, which I, coming out of residency, really loved because the hours were much better. And it felt just like kind of a relaxation moment after being out of residency. But it was shortly into my practice, so about 2 to 3 years, when I had the opportunity to work with residents again. And as a resident, I had loved working with students and interacting really with the team. So I thought, let's try it and see what happens. And in getting to know the residents and hear their stories and just watch how their brains work when they think about patients and cases, really made me see that there was a huge part of medicine that I wasn't getting to practice in just my outpatient only clinic. And I came to look really forward to the one day a week they were there and hearing about what's going on your medicine service, how is OB going, just all those little components of medicine I was no longer practicing, and really looking forward to their stories just to hear about those experiences. And that kind of triggered me to think, hey, maybe I do want to do full scope family medicine again, and maybe I do want to teach because I found it very rewarding to kind of even talk through some of those cases with them.
Coming from a niche part of medicine into teaching more broadly, I had to relearn some skills.
So when I first graduated residency, I had actually thought I would be doing outpatient medicine with OB. And that ended up not being the case once I got my first job, which I was okay with and seemed to do well with. And then as I thought about becoming a faculty and met with the residency to see what their needs were, if I would be interested in this position, it became apparent that they really needed someone who was going to do inpatient medicine as well as obstetrics. And at that point, I hadn't practiced those things in 6 years since I was outpatient only. So it was a little bit nerve-wracking to think about how logistically am I going to get comfortable with those skills again. And I think one thing I did that was very effective was using CME to actually do that. So the American Academy of Family Physicians had excellent CME courses for both OB and hospital-based medicine. And I was like, I have CME money, let's just give it a try. And I think that was really effective to just kind of remember and trust myself again. Like, I know this medicine, I just haven't done it in a little while. And then I think really partnering with my colleagues and our faculty at the residency to do that hands-on experience. And I think one thing we don't think about is that as faculty, we train residents, we train physicians all the time, and it's just a little bit different, almost just more expedited when you're retraining someone who's already been through that training. So kind of leaning into that and we came up with a proctoring plan. We're going to do, X amount of inpatient encounters and this many deliveries with the faculty. And that really built my confidence quickly because it's kind of, once you get back into it, you remember it, you know what you're doing, you learned it, you just kind of have to trust in yourself to get back into that. So I would highly recommend doing, CME as a starting place because that gave me a great foundation, and then building on that with, clinical encounters with your colleagues.
How did you retrain yourself to help build your confidence and knowledge?
So fortunately, the faculty at our program are very passionate about teaching, whether that's residents or an incoming new faculty member. But we really relied heavily on the connections we already had in the community, those individuals in those areas that are teaching our residents. So for the inpatient medicine, it was looking at the hospitalist colleagues we have at our local hospitals and saying, hey, we have a board certified physician who's been in practice but needs to get used to the hospital setting again. Can she work with you in that capacity, and partnering up with the obstetricians in the community to get back to, doing deliveries and those things. So it was really kind of just leaning on those partnerships that already existed. And I think that helped a lot in knowing that, okay, I'm going to be working with someone and teaching them, but it's not necessarily the same level or commitment that it requires to teach a resident that's still learning this. And I also think it was nice for me because now that I'll be in the hospitals doing those things, I have relationships with the people I pass in the hallway that are the hospitalists or the obstetrician. So it was really helpful to look into those relationships that already existed.
What was your biggest fear when you got started teaching, and how did that compare to the reality of teaching?
I think one of my biggest fears stepping into a faculty role was that I wasn't going to know the answer in front of a resident, and how would I handle that? That I wasn't really smart enough to be teaching, or didn't really trust myself fully, kind of that imposter syndrome that I think we all experience throughout our careers. And I think something that I kind of just had to step back and tell myself is it's also okay, and probably a really good teachable moment, to say, I don't know, let's look it up together, and to use that to, let a resident know it's okay to not always know the answer. And here's how we can go about finding it if we don't know. So once I was able to kind of talk myself through that in my brain, it really became less scary and kind of more enjoyable. I also think along the lines of imposter syndrome, it's important to just trust yourself. We've all been through training. We've been through residency. We would not have graduated or passed our boards if we weren't ready for this. So really just trusting yourself that you have this training. You just need to kind of freshen up on the pieces you may not have done in a while.
What does teaching fulfill that clinical practice alone doesn't?
One of the main things that really fulfills me in academic medicine versus clinical practice alone is the variety I get. And I really, in reflecting on it, think about why I chose family medicine in the first place. It was because I loved all the things. I loved all the ages. I loved helping people at various stages throughout their life. And in clinical practice, it's important, but you just kind of go through the motions every day. It's the same thing. And it felt just kind of like this wheel spinning, like there was never any true fulfillment. It was nice to help patients. I felt like I was helping my patients, but there weren't those moments where I got to see them in the hospital when they were, at their lowest. Someone else did that and took great care of them, but then they came back to me, and I felt like I was missing out on those pieces of their story. So coming back to a position where I can do full scope family medicine, it's nice to be able to say to my patient, yeah, if you get worse and are in the hospital, I will be there to take care of you. Or yeah, you decided to have a family, that's great. We can take care of you and your baby and throughout the whole pregnancy and even after your baby's born. So I really missed that piece of it. I also think, medicine has this huge administrative burden that isn't going away anytime soon. And when you're in clinical practice and just seeing patients, back to back all day, that gets really burdensome. And there's a lot of extra things that you just work after hours or work through your lunch hour for. And I think being in a residency setting, there's really designated times to do things. And it's not so much you have to figure it out on your own and take away from your life. We respect that you have a family outside of work, and that's important. And we're going to build time into your schedule to be able to do those things. I also really think I love that I can go to the hospital in the morning, see patients in clinic, and then staff with the residents all in one day. That variety is just amazing, and it's really fulfilling at the end of the day.
What do you find most fulfilling about being faculty?
One of the things that I find most fulfilling about being a faculty is the variety that it offers compared to clinical practice. So I can be in the hospital in the morning seeing patients and working with a resident, and then go to my own clinic and see my own continuity patients, and then staff with the other residents in clinic in the afternoon and watch them build those relationships with their own patient. And I think you just don't get that experience in clinical outpatient practice alone, because you're really focused on seeing your patients all day, every day, which is important. But the variety is really why I went into family medicine. So it's nice to have the variety within my day, not just within the ages and variety of people I see.
What advice would you give someone considering becoming a GME faculty?
I think for advice that I would give to someone considering becoming a GME faculty is to really go for it. It's very exciting. It's a new level of fulfillment. And I think if you have that inkling you would like it, you should really just try it out. When I was making this consideration, I had someone who I consider a mentor to me kind of describe why they love being a faculty. And they said they really think of it as the exponential number of people they touch with patient care. So you have your own patients and you make a difference in their lives, and that's really important. But when you're in GME, you can also see it as every life you touch through the residents. So not only when they're in residency, but then they go out to clinical practice and all the patients they see and the lives they've touched, you really have a hand in that because you're teaching them and shaping them and helping them to be that physician they're going to be one day. And as I was sitting with this person, we were having this conversation, that's when it really hit me. Like, I want to be a faculty. I want to be that person. And this is how I can truly make a difference on a bigger scale than just the people I see in clinic every day.
Leadership Academy Foundations of Medical Education video series.